Good morning. My name is John Lyons. As you were just told, I'm a board-certified general surgeon, but I did some additional training in surgical oncology. So I specialize in cancer surgery particularly, and I do a lot of work with patients who have breast problems, and in particular breast cancer. And I thought that we should focus this talk because obviously the most harrowing diagnosis for women in terms of breast is breast cancer. So I thought we should focus this talk on breast cancer and breast cancer screening in particular. Just to give you some numbers, this is the incidence, the number of women who were diagnosed with breast cancer in 2009. And that's the number of patients, women, who died of breast cancer in the year 2009. And this is the trend in terms of breast cancer incidence. This is the number per 100,000 from 1975 until the early 2000s. And as you can see, there's a little change here, but for the most part, the incidence or the number of ladies we've diagnosed with breast cancer has been relatively stable. There have been a few changes here, but not significantly. We're almost the same as where we were in 1975. But what you'll notice here, this is the mortality rate from breast cancer. This is the number of people who die from breast cancer. In the last 10 to 15 years, we've actually seen a reduction in the mortality rate, the number of people who die from breast cancer, suggesting that we're doing a better job at treating it. Well, why is this? This is multifactorial. One reason would be more effective medical therapy. We have more drugs at our disposal to treat breast cancer, more effective drugs. But the other thing, and the thing that we're going to talk about today, is the screening programs. We have implemented screening programs throughout the country, and they have been effective at identifying breast tumors at an earlier and more treatable stage of disease, allowing us to produce this diminished mortality rate. So today what I'm going to talk about is going to be basically the fundamentals of breast cancer screening, who needs screening, how do you get screened, and when, and what do you do if you feel a breast lump. So who? In general, anybody with breasts need to be screened for breast cancer. Having said that, though, there are risk factors that make someone a higher risk for developing breast cancer versus someone with an average risk of breast cancer. And these are things that you can do on your own to sort of assess your own risk. And this right here, I've listed this, this web page down here. This is at cancer.gov. This is a breast cancer risk tool that has a nice plug-in feature where you can enter all of this information in, and it will actually spit out a percentage of what they quantify as your breast cancer risk. But this has been validated amongst many different types of women in multiple studies. But it's important to know that your personal history of breast cancer. Ladies who have had breast cancer have a higher risk of having a second primary breast cancer at some point in their lifetime. Patients with a sister or mom or first-degree relatives with invasive or non-invasive breast cancer have a higher risk. Older women get the more likely a breast nodule is going to be a malignancy. Breast cancer affects women of all ages, but it's more commonly identified in women above the age of 50. When was your first menstrual cycle is important because it has been shown that women with a menstrual cycle younger than the age of 12 have an association with a higher incidence of breast cancer, and that's thought to be due to estrogen exposure. And similarly, patients who have had their first live birth at an older age are at a slightly higher risk, and then the number of previous breast biopsies. And this is a variable based on abnormalities in the breast. If someone has had multiple abnormalities identified in their breast tissue, it is associated with a higher likelihood that one of these will eventually be a malignancy. So these are things that you can sort of do yourself and know about yourself in order to assess your own risk. Now these.
So it's not the biopsy itself; it's the reason for the biopsy.
Well, it's both. It's both. It's the number of biopsies that you've had will increase your risk. So we've noticed that ladies that have had multiple biopsies have a higher risk of eventually developing a breast cancer. And it is the type of biopsy. It's both. Yeah.
Is it the biopsy itself or the reason for the biopsy?
It's both. Both.
I have a question. You say it's that age of first live birth.
Mm-hmm.
So meaning if you had miscarriage or stillborn, that doesn't count
That's right. That's right. These are other risk factors that are harder to quantify, but also need to be sort of in the back of your head. Oral contraceptive or hormone receptor placement, excessive use of alcohol, obesity, and certain environmental exposures. We know increase the likelihood of breast cancer, but are more difficult to quantify and can't be plugged into this sort of breast cancer risk tool like all of these other risk factors can. So an average risk woman is one that has no symptoms, no history of breast cancer biopsies showing atypia or what we call atypical hyperplasia or lobular carcinoma in situ, no family history of breast cancer in a first-degree relative, and no suggestion or evidence of a hereditary syndrome, which would be evidenced by family members that have breast cancer or ovarian cancer. And no history of mantle cell radiation. This is a type of radiation that was used to treat Hodgkin's disease that basically encompassed the entire chest. And it's less frequently used nowadays, but it was used quite a bit. And so if someone has had this done, this makes them at a higher risk for having developing a breast malignancy. So above average women would be people that have a family history of breast cancer, have a diagnosis of atypia on a breast biopsy or LCIS, or have had mantle cell radiation before the age of 32. How do we screen for breast cancer? Self-breast exam, clinical breast exam, mammography, ultrasound, and MRI. Now, self-breast exam is something that you can do at home and is recommended to have about every month. It's generally recommended that you do it the same time every month, especially in menstruating women, because the breasts will change depending on the time of the month associated with the menstrual cycle. And it's generally recommended to be done 1 to 2 weeks after the menstrual cycle because the breasts are less tender at that time. In general, it's recommended that the patient lie down flat, use 2 to 3 fingers, and work from the middle out in a circumferential fashion. And you want to examine from the collarbone all the way down to the top of the abdomen or the bottom of the bra line, from the underarm, and assess the underarm for any lumps or developments all the way to the breastbone. And it's important to remember that you're the first responder, okay? So it is important that you have clinical breast exams done by a physician, but in the interim, this is something that you can do on your own and assess for these things and notify someone if anything pops up in the interim. So things you look for, any new lumps, whether they're painful or not, any unusual thickened areas, any unusual discharge that is new, changes in the skin, and this is important because people don't realize, or a lot of ladies don't realize, that sometimes rashes or itching can demonstrate an underlying problem in the breast. And so it's important to recognize even skin changes. That can be a harbinger of something more sinister underneath. And then an unusual increase in one side of the breast versus the other. So self-breast exam, as I said, does not supplant the need for a practitioner to examine your breasts, but this can be something that's done in the interim, and remember that you are the first responder, okay? A clinical breast exam is something that's recommended and is done by a physician. This can be a family doctor. Typically, it's either a family doctor, an OBGYN, a lot of times will do this, and then also a general surgeon like me will do this as well. So they will ask you to take your shirt off, you will be placed into a gown, and then a clinical exam will be undertaken that will ensue an examination of the breast tissue and the axillary tissue, the lymph nodes underneath the arm, as well as the lymph nodes in the neck and in the supraclavicular region, the clavicle region up here. And things that you need to inform the physician will be obviously anything that you've found in the interim, and any changes in, any changes in the nipples, inversion, retraction, discharge, rashes or skin changes, and obviously if you're pregnant or menstruating, that's important information to know about. Mammography is another form, and this is the most common form of imaging that is used, radiological form of screening. Mammograms are an X-ray, basically. It's an X-ray that's used to image the breast in 2 views. Screening mammograms, and you can see this lady here having a mammogram, is done with the breast placed in the machine, and an image is taken in the cradiocaudal, or the up and down dimension, and then also in the side to side, or the medial lateral dimension. These images are then processed and given to a radiologist who looks at it and then gives a numeric grading based on what he sees, what he or her sees on the mammogram, and assigns as a number. And this is a nationally recognized, validated numeric scoring system called the BIRAD system, or the Breast Imaging Reporting and Data System. And based on 1 being seeing nothing, and 5 seeing something that's very highly suggestive of a malignancy. And most of the patients that I see usually have something in here. I see something, but it's benign, or I see something and it's probably benign. Ultrasound is another type of radiologic screening. This is a handheld probe that is used to image the breast using sound waves. And this is the same device that's used for pregnant women. So many of you have probably had this done during pregnancy, but this is simply a different probe that's used to image the breast. This is not recommended as a standalone screening tool, but it's typically used in conjunction with the clinical breast exam and the mammogram. And it's especially useful in younger ladies or ladies who have dense breasts, because those are typically less sensitive, less likely to be effectively imaged with mammograms. So it's a good conjunctive modality to use with mammogram and clinical breast exam. So MRI has had a lot of advertisements and a lot of discussion in the last 5 to 10 years or so, and I think it's worth talking about. MRI is a modality, it's illustrated here, that uses magnets, magnetic resonance, to image the breast. And it gives us very, very high quality images of the breast and shows us a great deal of the breast parenchymal architecture. And so we can identify many changes in the breast that are not seen with mammogram or ultrasound. But it has limitations, and it's important to point out that it's not recommended as a screening tool for average risk women. So it is appropriate for some women who have higher risk of breast cancers, but for average risk women it's not. And the limitations are several. One is that it obviously involves going through this sort of narrow machine. It takes about an hour or so to have done. It's expensive and not covered by many insurance companies. But more importantly, it has never been shown, when compared to mammography, to improve outcomes from breast cancer when it's used as a screening modality. And so that's significant. In general, it may be appropriate for some people, but not for everybody. When do patients need to be screened for breast cancer? In general, it's based on the risk. For average risk women, it's generally recommended that monthly breast exams, self-breast exams, start at the age of 20 or somewhere in the 20s. A clinical breast exam be performed somewhere in the neighborhood of 25 or so, and then an annual mammogram beginning at the age of 40. And we'll go through this again. Patients with a family history of breast cancer, it's typically recommended that a clinical breast exam be performed 10 years earlier than the age at which the family member was diagnosed. And the same thing with mammogram, that this be done 10 years prior to the youngest family member with breast cancer. Patients that have a diagnosis of atypia or lobular carcinoma in situ, these are lesions that have been shown to have to be indicators for an increased risk of breast cancer later down the road. They're not cancer themselves, but they have been shown to be associated with a diagnosis of cancer later down the road. So they need screening at the time of diagnosis, and then mammography, obviously, at the time of diagnosis. And then mantle radiation, this is typically given to younger women, and so it's important that they get screened with clinical breast exam and annual mammography 5 and 8 years after their radiation treatment. These are several of the larger societies in the United States. This doesn't represent all of them, but it's 4 of the big societies that have made statements on clinical breast cancer screening. And as you can see, they're all pretty similar. This is for average risk women, so this doesn't represent everyone. If there's a question of your risk and if you are higher risk, this is something you need to discuss with your practitioner, because the screening recommendations will change. But in general, a clinical breast exam, that's an examination done by a physician, needs to be done every 1 to 3 years, starting in the 20s, and then certainly every year after the age of 40. And then mammography beginning at the age of 40, and this is pretty consistent across all of these society groups. So to summarize, self-examinations start in the 20s. Clinical breast examination also start in the 20s as a baseline and be performed 1 every 2 years, or 10 years prior to the first-degree relative, or 5 years after radiation therapy. And mammography plus or minus ultrasound needs to be done as a baseline probably in the 30s or 10 years prior to the first-degree relative, or 5 years after any sort of mantle cell radiation, and then annually after the age of 40. And this is, what do you do when you feel a breast lump? We're not going to get tremendously into too much detail here, but I just want to sort of let you know what to expect when you feel a breast lump and sort of reassure you a little bit. If you detect a lump, obviously contact a provider. That may be your primary care doctor, that can be your GYN, that can be a general surgeon if you know a general surgeon. Usually what is undertaken is what we talked about, a clinical breast exam where the doctor will examine your breast and surrounding lymph node tissue, and then imaging will be undertaken. That will definitely include a mammogram, also probably an ultrasound, and maybe an MRI as well, and then a biopsy. And a biopsy usually is image guided, where a needle, the skin is numbed and a needle is inserted underneath the breast, and a sample of the suspicious tissue is taken and sent to the pathologist, where he or she then assesses it under the microscope and determines what this abnormality is. It's important to caution you that not all lumps are a cancer, and this is a list. This is not even a total list, but this is sort of just a list of different types of lumps, and all of these are benign lumps. So it's important to sort of take a deep breath and to get these tests done, but also to recognize that there are a lot of benign causes of breast lumps and a lot of things that we see. So that's why it's important for you to see a practitioner who can help you figure this out. So to summarize, try to be aggressive with your own health, get a feel for your own risk. Talk to your doctor about it. Remember that you are the first responder, so if you find something in between your visits to your doctor, don't wait until the next doctor appointment. These are some important contact numbers. There's a tremendous amount of information at these web pages. The Komen Foundation has a tremendous amount of information. The NCI does as well. And then this is my office number if anyone wants to talk about a personal case. Thank you very much. I will now open up the floor for discussion.